Hi, everyone. Welcome. Happy Friday. Thanks so much for joining us for Cadio's webinar series. We are super happy to be joined today by Dr. Lisa Uebelacker. Dr. Uebelacker is a professor of psychiatry and human behavior and family medicine at Alpert Medical School of Brown University. She is director of research at Butler Hospital, where she co-leads the Behavioral Medicine and Addictions Research Group. Her research centers on lifestyle interventions, including yoga interventions and physical activity promotion interventions, to improve quality of life for people with depression, chronic pain, and substance use disorders. So, Dr. Uebelacker, thank you again for being with us today. Super excited for your presentation.
Thank you, Jillian. And I do see some of my brown colleagues here too amongst the tiles. So glad to have you all. So thank you for inviting me to speak today. I'm excited to talk about a study that we have really just completed data analysis. We're working with Jillian and Kate to really kind of figure out the last pieces of interpretation to go into a paper. So you're really seeing kind of the, this is really the final version before we send the paper out for review. So I'm excited to share this with you and then also discuss some of the puzzles that we have puzzled our way through or are still puzzling our way through. So I'm going to share my screen. So the informal name of the study is Yoga Medication for Addiction Treatment, MAT, Yoga Mat. And you can see here our beautiful logo that we really loved having designed for the study. So a study using the multi-phase optimization strategy framework to develop a yoga intervention for people with chronic pain who are taking opioid agonist therapy. And here's my name and my spelling. I will mention the other PI on this study is Michael Stein. We have with us Brad Anderson today, who is our data analyst, and also Bailey O'Keefe, who's been helping us with data and with the study. So just brief background. Opioid agonist therapy is the standard of care for people with opioid use disorder. And this can include buprenorphine and methadone. And those, we recruited folks for this study I'm going to tell you about who are taking buprenorphine or methadone. Rates of chronic pain are very high in this population. And sometimes it may be that the chronic pain preceded the opioid use disorder. Maybe somebody had an accident or injury, had chronic pain, were prescribed an opioid medication, and that kind of rolled into an opioid use disorder. Also, having a substance use disorder may increase your risk for injuries and accidents, which can then lead to chronic pain. So the rates are quite high. And chronic pain is really undertreated in this population too. There's not always a lot of resources available. Physicians and other providers may be kind of nervous about treating chronic pain in this population. You'll see folks tend to be pretty low income, so they don't have a lot of resources. So there's a real need to think about how can we help people with opioid use disorder and chronic pain really cope with that chronic pain in a healthy way. So what is yoga? Yoga is ancient. It's an ancient set of practices and philosophies from India. It's not sort of just your gym jumping around kind of thing. It really, the full package includes ethical standards and practices, postures, asana practice, the movements that we think about when we think about with yoga, breathing practices, a lot of attention to breath, and also altering breathing patterns, maybe slowing down the breath, which can have a salutary effect on increasing activation of the parasympathetic nervous system. And then really when you go in deep, self-study, meditation. So it's kind of this full package. really focused on bringing harmony between mind and body. And when we think about yoga and what will be important for this discussion today is we think about a yoga class where you learn yoga practices, especially if you're new to yoga, but really practicing yoga on the mat and off the mat. How does this affect your everyday life? How are there brief practices you do in everyday life to really support yogic coping skills, like slowing down your breathing when you're feeling really stressed, to give you a moment to kind of cope, step back, cope, maybe cope with urges to use substances. How can we slow you down, help you to step back, observe that urge, and coping with chronic pain as well. So how can you use the skills that you learn in a yoga practice to really cope with these stressors in everyday life? So there's a decent body of evidence that yoga can be useful for chronic pain, less for substance use disorders. So we have data about yoga for chronic low back pain, headache, rheumatoid arthritis, fibromyalgia. And we think that it's both the mindfulness practices are important, but also, as you can imagine, with chronic low back pain, the movement is important too. It's important to bring gentle movements into your body to help with the pain. So there's a fair amount of pretty decent research on yoga, especially for chronic low back pain, much less on substance use disorders. And I show you just a couple pictures. I'm not going to go into depth on the way we teach yoga for this presentation, but I wanted you to see this picture of the person with the chair. So those of you who are yogis may be familiar with down dog, which is similar, but your hands are on the floor, and it's actually quite it can be a challenging pose. So we do a lot of modifications. We ask everyone to have a chair for balance, but also this stretch, which we call take the chair, is a version of down dog, which provides a really nice stretch to your back without you having to get your hands down to the floor. So I just wanted to show a little bit about the way we teach yoga. So my colleague, Dr. Stein, and I did a pilot study of yoga for chronic pain in people who are taking opioid agonist therapy for opioid use disorder. We did it at STAR, which is a federally qualified health center in Fall River, Massachusetts. First, we did some focus groups. We had some really interesting focus groups where we were talking with our target population about possibilities for the yoga intervention. We did a pilot randomized controlled trial, 12 weeks of yoga classes versus health education. Classes were once per week. We recruited folks in the methadone clinic. We recruited folks in the buprenorphine clinic. And our goal was really to assess feasibility and acceptability, right? So this is our R34 for many of you who I'm sure are familiar with that mechanism at NIH. So in terms of feasibility and acceptability, retention for assessments was excellent. The teachers showed good fidelity to their manuals. The intervention was credible. They expected that the yoga intervention might be helpful. They were satisfied with the program. However, class attendance fell quite below expectations, what we were hoping for. Many of the reasons for low attendance were not related to the study intervention. Many of the folks we recruited have a lot of things going on in their lives and a lot of things that prevent them from getting to class. Transportation, health conditions, just things changing in their life, having to care for loved ones, job changing, just a lot of different things going on. Personal practice, which is what we call home practice, kind of acknowledging that not everyone has a home that they live in. So personal practice, which is any practice outside of class, almost met expectations. So we had wanted to see 70% of folks practicing at home at least twice per week. So people were practicing some things at home, and we did give them a mat and ideas about videos and instructions to try to support home practice. And we got some really nice positive feedback. It makes you feel better physically and mentally. It's mind, body, soul. By dealing with all three of these, it actually addresses health issues. Teaching you to be aware of your body is huge. Great for recovery. Makes it possible to shift perspective in a time of change. Okay, so we got this far. So we did this feasibility study and we just weren't quite getting the engagement that we really wanted. So what do we do? Because here's the thing about yoga. In order for it to work, you have to do it. You have to do it sometimes. In class or independently, it just doesn't work if you don't do it. And if we were going to do an effectiveness trial, we want to test a yoga intervention that maximizes engagement, right? And if we want to show that it works, we want to make sure people are doing it so we don't have null results because we were unsuccessful in engaging people. So the question was, what intervention components, when added to a weekly yoga class, would maximize engagement in class and personal yoga practice? And we wanted to look at both class attendance and personal practice, right? Because there are definitely barriers for class attendance. So what do we do? So this was, I don't know, 6 years ago. What do we do? Well, I went to SBM to take a workshop. Linda, apologies for not having your picture here. I have Kate's because Kate is the one that I really grabbed onto and followed up with. And I learned about MOUD. I learned about the MOUD framework and more about intervention optimization. So that leads us to this current study. That's how we got there. So we thought about, okay, we have this class. And so if you look sort of on the side, the going up and down, standard Hatha yoga program, weekly 1-hour classes, plus guidelines for home practice. And then we had a number of different ideas for components that to my implementation scientist colleagues that I see here are some of which are kind of implementation, ways of implementing, ways of kind of getting people to engage, maybe all of them are. So we had a number of components that we wanted to add on to see if we could increase dosage received. And to operationalize dosage received, we said it's the time in yoga class plus the time in home practice. So that's what we wanted to increase. With the idea that, again, you need to engage in yoga in order for it to work. And there's some evidence in some kind of glimmers, pieces here and there in chronic pain and maybe in depression studies that when you do more, it has more benefit. And I'll just say, we just weren't worried about people doing too much. We just did not have that worry. So the idea that the more you engage, the more possibility that it can, that your engagement in yoga can reduce interference due to pain, reduce pain severity, improve quality of life, and improve substance use outcomes. And you'll see that we kind of thought about potential mediators for these different kinds of intervention components. So we submitted this. This was at a time when NCCIH had it was a UO1 that was combining kind of, they were very interested in intervention optimization and feasibility studies. So that's what we submitted to do intervention optimization and feasibility in 2, which became 3 sites. And ultimately that's what was funded. So to kind of go through the intervention components, we called it component 0 because everyone received this weekly. So here it says remote. It was originally going to be in person. When I submitted the grant, when we submitted it, it was in person. And then we received the grant in April 2020. And we received the grant, and I don't think Michael's here, but I said to Michael, like, what are we gonna do? We can't do this. We're supposed to have classes at these clinics like we did in the pilot. What are we going to do? And Michael kept telling me, no, this will be better because we'll have a wider reach. We'll be able to reach more people if we do it remotely. And ultimately, that's what we had to do. That's what we had to do. And we gave people devices to use so that was not a barrier. So weekly remote synchronous, so live 1 hour yoga classes. Participants were invited to attend one of 3 time slots for 12 weeks. They had the cell phone and we sent them a yoga mat. And then we looked at these 4 components to look at how so that we could look at how they impacted minutes of yoga per week. One was study specific videos. So in many of the studies I've done, we give people recommendations, kind of a curated set of YouTube videos. But here we thought, well, maybe here we had the yoga teachers create study specific videos that were very consistent with what we were doing in class and had, the familiar yoga teachers. Component B was private sessions, the opportunity for 2 one-on-one private sessions with one of the study yoga teachers. Component C, text messages, daily text messages, really designed around kind of self-determination theory to really cue internal motivations, positive internal motivations for engaging in yoga practice. And component D, incentives for class attendance, $15 per class attendant. And sort of incentives and or contingency management have a pretty substantive history in the context of substance use disorder treatment. Study timeline, randomized at baseline. We have this factorial design. Each of those 4 intervention components is on or off. They're active in intervention for 3 months, and then we had follow-up assessments out to 12 months. That was sort of the feasibility component of what we were doing. So as I mentioned, the primary outcome for this study, what we want to optimize minutes per week of yoga practice, time in class, plus self-reported personal practice. The great thing about time in class is it's perfectly observed. Personal practice, we were assessing weekly whenever we could and using, if not, kind of filling and missing data using a timeline follow back method. We also looked at related adverse events and likelihood of attending the month 3 assessment. So, and we didn't have any, our plan was to choose the intervention, the combination of components that led to the most number of minutes per week. We didn't have any financial constraints or anything like that on what we were on planned. So here's our consort chart. We enrolled 192 people. And ultimately using all available data, and Brad can speak to this, we included everybody in the analysis. And we had at least some follow-up data for, I think it was 187 people. So here's our 192 participants. It ended up being over 3 sites. Age 44, 2/3 female, 1/3 male. You see our racial and ethnic composition of our sample, 53% below the poverty level. So that's kind of family household income by number of people in the household. And of course, everyone had chronic pain. So we collected all of our data, and Brad and I and Bailey spent a lot of time together. Ultimately, first calculating our primary outcome, and then once we were ready, we we were masked to the identity of each intervention component. They were just labeled A, B, C, and D while we were working on fitting a model to our data. Each intervention component was effect coded -1 or 1, but we didn't know which ones were reverse effect coded. So we spent some time working on finding a model that fit our data, because our data were very zero inflated. We set alpha at 0.10. Our model included main effects, 2, 3, and 4-way interaction effects, weak, and then some covariates. And ultimately, after consideration and consultation, we decided the best fit was this zero inflated negative binomial model with constant only included in the inflation part of the model. Brad can answer questions about that later. So what do we find? So we found a main effect for B, which turned out to be private sessions, which increased yoga engagement by an estimated 12 minutes per week. So then we had this interaction effect that we were talking about, increasing engagement by 23 minutes per week relative to the grand mean. And then we had this interaction effect, which we've looked at and sort of puzzled over. A is access to study-specific videos by the study teachers. And I can tell you from our data, we don't have data on who accessed what at what time, but we know that they weren't accessed very much. And there was some real complexities. We tried to make it as easy as possible for people, and yet it wasn't that easy for people to access them, even though we tried. When people don't receive study-specific videos, we see very clearly here that this interaction where incentives for class attendance and private sessions yields the best outcome. The left axis is minutes of yoga per week. When A is turned on, we're not, honestly, we're kind of at a loss for how to interpret it. Although we also think it's not going to affect our decision-making in the end. But if we want to discuss these interactions, we could discuss them at length. You'll see in the third graph, regardless of A, the best, the combination with the most number of minutes per week has both B on, so private sessions, and D, incentives for class attendance. And so we really, we started to, we really wanted to consult with Jillian and Kate, like where to go for here, thinking about, again, a decision-making perspective. And Jillian introduced us to Dave, or Y-hats, where we looked at the predicted average cell means, the model predicted average cell means. And what you see here at the very bottom, this is B on, so one-on-one sessions, C, text messages, which didn't really show up anywhere else, and D, incentives for class attendance, has the highest model predicted cell mean. The other thing which we'll come back to is Jillian put it, I think, third best is none. Third best is none of the added components. You can see this XXXX, which is third up from the bottom. I'll mention other results, but those are the primary results. So sensitivity analysis really didn't change our outcomes. There really wasn't much in the way of adverse events related to the components. We did look at the likelihood of completing the month 3 assessment as a secondary outcome. where we see, again, component A decreased assessment completion at month 3, and component D, incentives for class attendance, increased assessment completion, even though everybody got the same incentive for completing the month 3 assessment. We looked at minutes of personal practice that really mirrored the primary outcome. And then we looked at number of observed classes attended. There was only one main effect, which was component D, being paid for class did indeed increase the chances of attending class. So kind of in our decision-making phase, we thought about what is the optimized intervention here. And luckily, again, I want to hear your all feedback. The results seem to really converge around we have this weekly synchronous class, and then adding component B and component D, certainly. And then according to the Y-hat analysis, we would put in daily text messages as well. This is something that we can kind of come back to for discussion. The average minutes of yoga per week was substantive. Like Brad was saying, he remembered the number 127. So that's time in class plus personal practice. And we did really emphasize personal practice in this study, in any of the studies we're doing. And that's one difference between how we present, how we do yoga classes from community classes. You don't hear much about personal practice in community yoga classes. We really try to emphasize it because we really think it's the way to help people gain much more benefits from their yoga class, bringing it into their day-to-day life. We did look at the mediators, and some of them were just flat lines. Like whatever we were measuring was not, I don't think, what we thought we were measuring. So I don't have more discussion here about the mediators because they just didn't, they just didn't change. They didn't change. So, it's like self-efficacy for yoga class. It just didn't change. And I actually think that once people got more engaged in yoga, they might have seen like, it's actually kind of hard to get there. So more engagement might have led to less self-efficacy. Whereas when you first start, you're optimistic. Oh yeah, of course, I'm going to be there every week, everything. So that was a challenge. So anyway, we can come back to this. Let me just mention the feedback from the participants. I just wanted to say how grateful I am to the yoga study over the last year. It has transformed me into a much more positive, healthy, and athletic person. Since doing yoga, I've also seen and felt a change in the speed of my healing. I'm much more conscious of the food I eat, and I make sure to do some exercise on a daily basis. Yoga has changed my life, and I never knew it would have if it wasn't for the study, right? Because we were going into these substance use disorder clinics and recruiting people who do not show up at your $20 a class corner yoga studio where lots of folks are wearing, fancy yoga outfits and things like that. You're not gonna find them there. So we're recruiting people who are really don't have this opportunity or don't feel comfortable in some of the community opportunities for yoga. While I was doing it routinely, it really worked. I was skeptical at first, but it really worked. I would do my own levels and listen to my own body. That's a big message, listen to my own body. If it wasn't for you guys, I would have been screwed. If I would have known that I could do something so small and it would help my pain so much, I would have done it a long time ago. So of course, these are anecdotes. They're anecdotes. This doesn't apply to everyone. There are people for whom yoga is not helpful, of course, but it is really helpful for some folks. Next steps, thinking about how to do this, can we look at the optimized intervention versus a control group, kind of the third phase of the MOUD framework? Looking at brief pain inventory, looking at pain outcomes as primary and secondary outcomes, substance use, quality of life outcomes. But we're just sort of metabolizing this first trial right now. I want to acknowledge all of co-investigators who are fantastic. It takes a lot of people to do this work at a lot of clinics, a lot of places, and also research staff, clinic staff, yoga teachers, safety monitoring committee, and of course all of our participants. And then this work that I shared with you today is primarily funded by these two grants from NCCIH. So I do have this slide I can go back to if we need to, but open it.
Okay, great. Great. Thank you so much, Lisa. So interesting. To our attendees, you can, as usual, put a question in the chat if you have one. And you are also welcome for this question period to raise your hand if you'd like to join the conversation. I want to just launch into some questions, Lisa, here with one from the chat. Will you repilot the new intervention before doing the larger intervention versus control trial?
I don't know. How's that for an answer? On the one hand, I've never regretted doing a pilot. On the other hand, it may be hard to convince funders that we should do that. One possibility, and I skipped past this here, for this study, we actually did a phase 1 where we piloted the factorial design in, I forget if it was like 16 participants or something like that. We did do a pilot because we wanted to pilot all the factorial, you know, making sure people got what they were supposed to get, all those kinds of things. So I think that would be, again, I've never done a pilot that I've regretted, but we'd have to convince funders that we should do that. It's a good idea.
Great. So a next question from Linda in the chat. For an intervention like this to go to scale, of course, someone would have to pay for it. Who would that be in this case? Would an insurer pay for it, and would they pay for the $15 incentive?
So let me address the $15 incentive. The reason there's some hope for that is, again, because there's this real push. There's a real history of contingency management in substance use disorder populations. And so, for example, we work with Boston Medical Center, and they're doing contingency management in their stimulant use clinic. And I'm not sure exactly where, if they're getting the funding from the state from that, but they are getting funding for that. So there's some hope for that in the area of substance use disorder.
Lisa, can I just push back a little bit, because it seems to me that, well, let me back up. Are they getting funding for research or funding to implement the intervention?
Implement.
So, oh, okay, wow, that's great.
Yeah, but you know, and it's this tension between what is going to be feasible in the long-term healthcare system, in the short-term healthcare system, and how much do we want to change the healthcare system, because it needs to be changed and we need to push to change it so that it works. So there's a real tension there.
Mm-hmm.
A lot of why I think about our yoga research is we need to demonstrate data to show that it works in order for people, healthcare insurers, to consider paying for it.
Mm-hmm.
Right? They don't pay for it. Right? Although then you look into these little pockets, like we have a Blue Cross store in Rhode Island, and you can go there for free if you're a Blue Cross member, and you can get yoga classes there. So they're sort of paying for it.
Mm-hmm.
But I feel this real tension between designing something that will work in the healthcare system as it is right now, which is a disaster, as we know, versus trying to say, how can we push the healthcare system in a direction and argue that we should be paying for things and move in that direction.
Okay, so what you just said, I think, is really interesting, and I could not agree more that our healthcare system is a mess and a disaster, and one of a growing list of reasons why it's difficult, why life is difficult for many people in the United States right now. But so I could imagine optimizing your intervention a slightly different way. What if you had payers at the table? What if, you and Jillian and Kate and the rest of the people who are involved in the study had potential payers there and asked them, how much would you be willing to pay? Let's look at the Dave plot and what do you
Mhm.
think about this array that's on the frontier of efficiency? Does one of those do it for you?
Mhm.
I'm just wondering, what you think of that because I mean, I'm a pointy-headed methodologist who doesn't go out in the world very much, but I do think about these things, and you're, you know, out there in the world, and you have a better sense of whether what I said just now is even possible.
We're still trying to have on the table, should they pay for yoga at all?
Hmm.
And is there sufficient evidence that it's worth paying for? So my concern with that, and we've, with some of our other studies, we've talked with various people from some of the healthcare systems saying they need more data to show it's helpful
Hmm.
before they're even willing to talk about should we pay for it or even how
Hmm.
much.
Hmm.
Um, yeah, that's not a satisfying answer.
Well, maybe there's not a satisfying answer, but when they say we need evidence that it works before we would pay for it. In a way, I feel like that's a brush off because um, they're not going to pay to exaggerate this just to make my point. They're not going to pay $1 million a person for a tiny
Yeah,
tiny effect.
yeah,
So there is somewhere in someone's mind there's a minimum effect that they would be willing to pay for, and then the question is
yeah,
how much would they be willing to pay for that?
yeah,
But we never seem to have those conversations.
yeah. No, I think it's I'm thinking about someone who I have worked with in our neighborhood health plan and who would at least who might engage with the question. Um, and right at this moment in time, no one's going to engage with this question. I don't
Yeah,
think it's just
yeah,
right.
yeah. No, I mean, I completely understand that. But I just want to make one more quick point, which is that we are now with intervention optimization, we're at a point where that conversation could be quite different than it would have been 10 years ago, right? I mean, 10 years ago, you would have done um, a regular treatment package, RCT, and that would have been a fait accompli, that's it. Funder, this is what you get. And do you like it or not? And that's all, that was how the conversation would be. And now we have intervention optimization and the Dave plots where you could actually talk to someone about what are how high are you willing to go, and maybe it should be this one on the frontier of efficiency, or maybe this other one, and that just seems like a different and potentially more productive conversation to me.
Mm-hmm. And how do you kind of balance the sort of efficacy versus effectiveness? If we want to do an efficacy trial, we really want to maximize engagement, right?
Hmm.
But effectiveness, you have to start thinking about, but what will they let us actually do in the world,
Right. Yeah. Yeah.
right? And are efficacy trials useful? Are they useful,
Hmm.
right? Is it worth just trying to show it can work if we put enough oomph into it? Is
Hmm.
that worth showing? Is that not worth showing anymore?
Yeah. That's an interesting question, and one that I would love to talk with you about at length. My personal feeling is that if the oomph is gained, and I know what you mean, but if the oomph is gained at the cost of assembling an intervention that in reality could never be implemented, it's not
Mm-hmm.
worth it. That's my feeling.
Mm-hmm.
But one could argue that. But up until now, what everyone has been doing is trying to get all the oomph and most of the and I see why, but a lot of the interventions is just, no, it's just that's great. Nice for you that you made it work, but no way that's ever going to happen in real life.
I think, based on this trial and probably qualitative feedback, the thing that I would go to the mat for is offering 2 one-on-one meetings with the yoga teachers.
Mm-hmm.
I think that's the thing that teachers and participants found them very useful.
Yeah, and
And it
that's
makes a lot of
expensive, but
sense.
it's expensive, but it makes a lot of sense, and it looked like it was really worth it.
And there is this movement in the yoga world. So the International Association of Yoga Therapists is working towards getting CPT codes for yoga therapy,
Mm-hmm.
which would be sort of akin to these 2 one-on-one sessions.
Yeah.
So they're actually moving it in a different direction. So if based on this entire trial, if I could do just one thing, that's what I would press for.
Yeah, and that's so great. And there's no way you could have found that was like the one hill you want to die on. You couldn't have found that out with a traditional treatment package RCT.
Right. And in fact, with the videos, for another study that we did, we had proposed making study-specific videos just as part of the package, part of the effectiveness trial. And the funder, which was PCORI, pushed back and said, no, don't do that. Well, turns out maybe it's good we didn't do that. Maybe that would not have been worth it at all. Different trial, different population, but I'm not going to make study-specific videos at this point. But I do think those one-on-one meetings are really important.
Yeah, well, people can get one-on-one psychotherapy sessions covered. It makes perfect sense that people who have chronic pain should be able to get one-on-one yoga sessions covered. It seems to me like it's much the same thing. Thank you. I don't want to monopolize the conversation, but this is really interesting, Lisa.
Lisa, there are some questions about the finding that the all off or all to their lower level was the third best. And I want to have some time to discuss that. But before we turn to that, I want to also ask one other question. Can you tell a little bit more about your decision to optimize on the number of minutes? It seemed like that was a more proximal outcome in your conceptual model. And what made you choose that versus optimizing on the more distal outcome in the model?
Yeah, I think it really came out of that pilot study where we were just folks were not attending class as much as we wish they would. Although, and I'll say we wish they would, because we don't know what the right amount is. We do have some different pieces of data that suggest more time engaged in either personal practice or a higher frequency of class attendance. There's some signals that more is, like I said, has a better, is associated with better functioning related to pain. So I think that we were just thinking, like, how can we really engage people? Because if we can't engage them, if we can't get them doing it, there's no way it can have an impact on pain or anything else. So that was why. And then when we thought about engagement is obviously a lot more complex than minutes of practice per week, but that was the best kind of approximation that we were able to come up with. But really the thought was like, some people were having trouble engaging, we're having trouble getting them come to class. But they were also telling us in that previous study, but I'm practicing at home. one lady came to 2 classes and then told us, well, I went to the hospital. I was having problems with my insulin, and I was laying in the hospital bed doing the breathing exercises you all taught from 2 classes. So clearly personal practice seemed important too. So it comes back to this thinking, like, you have to do it, and you have to probably do it more than like once in a great while in order for it to help.
Mm-hmm.
So that was our thinking.
Yeah. Yeah. So as you look ahead to the next steps and putting in a proposal for the evaluation phase and a 2-arm trial, have you thought about your strategy in terms of the adjustment that you're making in terms of the outcome? So now you optimized in terms of the engagement in yoga, and then you'd be evaluating in terms of pain, I think you said. Have you thought
Yes.
some about the strategy for that pitch?
Yeah, I think that was always the plan, right? It's we don't engage in yoga to see how much we can engage in yoga. The point is to see how much can we help people with pain, right? So I think that will be a pretty easy sell. And then we can absolutely look at, does amount of time engaged in yoga, well, does amount of time engaged in yoga correlate with the outcome? You would expect that the control group might have 0 engagement. So I don't know, we'd have to think about, like, how does that work as a mechanism if you expect that the control group has 0, although they might not have 0. The reality is. But we could look at how much engagement is correlated with change in pain interference over time in the yoga arm.
Yeah. Yeah. Interesting.
Which is some of the work that we did submitting this grant application, like looking at Dr. Shaper. He's done a lot of the work in yoga for chronic low back pain, looking at change in functioning related to pain and amount of yoga practice over time, and kind of seeing a correlation.
Mm-hmm. Mm-hmm. On a somewhat similar note, another question is the grand mean that you mentioned seems high, and is that true? Do you see that as a sort of everyone was participating in a decent amount of yoga on average in the trial?
It did seem it was higher than in our pilot, although I think, we added these components in order to make it higher. Our pilot, so it was definitely higher, and it was higher than I expected. And not everyone did yoga. Some people did none at all. We definitely had 0s, right? And so the question is, was it higher than I expected, or?
Just did that seem high to you?
Yeah, so I'll tell you, it did. And we scrutinized our data. We looked at all of our outliers. We went back to the audio recordings. We double checked them. Yoga practice can be, we included asana practice, breathing, breath awareness, meditation practice. And so some people would tell us, I went for a walk and I was maybe an hour long walk, and I was focusing on my walking the whole time, right? So doing kind of a meditation sort of practice. And that's kind of part of the components of yoga. We've got the asana, the breathing, the meditation. So we did our best. We asked people, how much time did you engage in yoga practice? What were you doing? We scrutinized all of the kind of larger numbers, because some people definitely had larger numbers. But it seemed, we have the audio recordings. I don't know, it seemed legit, but large. I mean, maybe part of it too is some of these folks don't have a lot, they may not be working for pay, so they may have some extra time to spend engaging in some of these practices than other people who are working full-time for pay or things like that. Some people just really liked it. And we really emphasized it. When we were thinking about how much do we ask people to practice on their own, we sort of looked at physical activity guidelines, right? And said, well, 30 minutes a day, 5 days a week. And we looked at that as sort of the aspirational goal, right? We looked at that as aspirational. So we were really emphasizing practice. At the same time that this is yoga, we're emphasizing being compassionate towards yourself when you don't practice. But we spend a lot of time talking about personal practice with people.
Yeah.
Which maybe has its own effect on personal practice, just asking about it all the time, right?
Right. Interesting. Good point. Linda, to your question and to the other questions I've received about the all lower level being the third best. We've had various conversations about this finding, and I think a lot of it has to do with a very high magnitude three-way interaction that had the negative sign, and some other interactions that also had signs that contributed. When I've looked at the factorial table, though, a lot seems to come down to this very large magnitude three-way interaction that was much larger than the other coefficients.
Yeah, there's a lot to digest in any factorial optimization trial. Of course, that's that's the kind of result that you would never see if you did a straight treatment package RCT. It would be there, right? It would be there, but that is to say that that combination of components would have that effect, but you would just wouldn't be able to detect it. So it's certainly something to ponder.
Yeah. And another interesting reminder here I'll just throw out there is the amount that's in the core intervention that everybody receives. So that all off is not nothing. It's just the lower levels and then the baseline core intervention.
And I have to say, it's the talking to the research staff who are trying to get assessments of how much you're engaging in yoga each week. And we did not do that by just like a self-report questionnaire, because we knew we wouldn't get the data if we did it that way. So the staff would call them. It would be a brief call, like 2 to 5 minutes, but the staff would call them to get that data.
Interesting. Yeah, so in a sense that's part of the core intervention that everybody received.
Yeah. And of course, we hired compassionate, kind staff. Yeah.
So I
Well,
would just, if I can jump in, one of my thoughts after years of doing a lot of this kind of work is, uh, you know, even the control arms get a lot of attention.
Yeah.
And I sometimes think we'd be better off having like a non-treatment control to actually see what the treatments do relative to nothing. I mean, that won't get funded in this environment or maybe any environment, but there's a lot to just interacting with RAs and having people talk to you and care about you, and so
In this population, unfortunately, being treated with respect is not necessarily the norm. So being treated with respect might have an impact.
Yeah. Wow. Well, I'm conscious of the time. Thank you, everybody, for being with us here today. Thank you, Lisa, for such an interesting presentation and this conversation. Everyone, I hope you'll join us on December 5th for the last webinar in our fall series. And thanks again.